Thanks, Cheryl. I'm not going to introduce myself again because I think you know who I am. But Rod, did you want to just say?
Yep, sure. Hi, everyone. Rod Naylor, Clinical Science Liaison. I'm a respiratory therapist as well. Haven't put hands on patients in a while, but I graduated a while ago as well. You can probably tell by the gray hair, although it was early. It was early onset gray hair. So, but anyways, yeah, I'm going to help Stephanie. We're going to talk about severe asthma today, and hopefully the way that CREs can engage in identifying and elevating the care of severe asthma patients. So I'll let Stephanie start.
Great, thanks, Rod. So shifting gears a bit, the objectives for today, we're going to discuss when your asthma patient should be referred to a specialist. We'll also discuss something called the Delphi Consensus Guidance on Severe Asthma and how this could potentially change practice, especially for Canada. And we will review biologics that are currently used in the management of asthma, and Rod will give a really nice outline of all the ones that that are available now. There's been quite a bit of evolution in that biologic landscape. So just to put in perspective, what is the situation with severe asthma? What does that burden look like in the Canadian landscape right now? So there's about 8.4 Canadians who have asthma, but it's a really small subset of that population that have severe asthma. So only 5 to 10% of that. But disproportionately so, this small population accounts for up to 50% of the direct costs of asthma and a similar proportion of the indirect costs. Unfortunately, severe asthma remains uncontrolled, and patients remain uncontrolled in spite of high doses of ICS/LABA therapy as well as long-term OCS use. There's also harmful effects of chronic OCS use, and that long-term OCS use is associated with significant adverse events, and those bursts that happen every time they have an exacerbation, those two contribute to that. What we used to think was an acceptable amount of OCS for our patients, we're learning more and more, particularly through the work of Dr. David Price as well, that threshold is getting lower and lower, and there may not be a safe dose from what we know now. Morbidity and mortality. Severe uncontrolled asthma is associated with exacerbations, debilitation, impaired quality of life, as well as that increased risk of mortality. So how do the definitions of severe asthma differ? So CTS, as we know, 2017, this is actually under review. This is a position statement. But what they said in 2017 was that severe asthma is one that requires the treatment of a high dose of ICS plus a second controller and or systemic corticosteroids for 50% of the year to prevent it from being uncontrolled, or which remains uncontrolled in spite of this therapy. Now with GINA 2023, it's a little bit different the way they describe it, and they identify severe asthma as a subset of difficult to treat asthma. And difficult to treat asthma is not necessarily severe asthma. But asthma, they define it as asthma that's uncontrolled in spite of adherence to maximal optimized high-dose ICS/LABA, as well as you've also assured that there's a management of contributory factors. It's the type of asthma that worsens when that high dose of treatment is decreased, and it is something called, it is often the term refractory has been used. However, this is evolving with the new landscape that we have with the biologics now. So we may no longer see the use of refractory as much when we're discussing severe asthma. And just as a visual, this is from the 2023 GINA recommendations, and we're really talking about that step 4, step 5 population here. So I'm not going to go into detail of this, but what this is meant to show is that just all the different complex processes that can be involved with severe asthma, that it really is a distinct disease. And patients with severe asthma can present with everything from eosinophilic inflammation, mixed cellularity, high levels of IgE, nasal polyps, sinusitis, just to name a few. And Rod will go into this a little bit later to show that there's with all these different pathways, we now have multiple treatments that can target many of these different pathways to give a much more personalized medicine approach to these patients. So what are some of the challenges and what can we do to start overcoming these barriers? And so this has been grouped into 3 categories. So first, awareness of severe asthma is limited. We need to petition for healthcare system change. We need to understand that recognition of severe asthma as a distinct form of the disease. Patients are often not referred for specialist care, and this is a conversation at the primary care level. How can we improve disease identification with our primary care counterparts? How can we facilitate, expand referral networks, accelerate those referrals so that these patients are getting access to these biologics in a timely manner and preventing all these consequences that we're seeing with these long-term effects of OCS use. And actually, when Rod speaks about the Delphi, that'll address this a little bit. Capability and capacity varies dramatically. We need to increase the knowledge and confidence. We need to expand capacity. We need to reduce oral corticosteroid use and increase that access to advanced therapies. We need to challenge that normalization that chronic OCS use is an acceptable form of treatment for these patients. Now, OCS definitely in the emergency situation, it's effective, it's hugely effective, and it'll always have its place. But now that we have other options, can we do better for these patients? So with a group of series, I'm sure you guys do this already. I'm not going to go into detail of it, but it is always a reminder of consideration of other factors that could be contributing to the uncontrolled symptoms. I'm always curious, like if we just gather everyone in a room and share all the different ways that we've seen people use inhalers in the past, I think it would make for a very interesting discussion. And I know sometimes it can be amusing sharing these stories, but at the end of the day, it means that these patients were not getting the therapies that they needed. So really making sure not only the technique, but they're taking the medications that are more aligned to them and their lifestyle, that they're included in that process as well, checking their adherence, checking their comorbidities, as well as risk factors and triggers. Check the use of short-acting beta agonists, and that's something that's been mentioned in the CTS guidelines in 2021, and we'll speak to it just shortly after as well. Checking anxiety, depression, social and economic problems in this population, and as well as checking the side effects of medications. So just teasing out a little bit on that short-acting bronchodilator use and what we're learning about what happens when it's being overused. So back in 2020, there was a publication, a global look at the prevalence of overuse of SABA in many different countries, Europe, as well as Canada, United States. And they looked at not only what was the prevalence of overuse, which is defined as 3 or more canisters a year, but what were the consequences associated with that practice? And what we found, first of all, was that in all the countries studied, overuse was certainly a problem. In particular, we studied Nova Scotia and Alberta in Canada, and in both provinces, there was a significant amount of overuse, 3 canisters or more in these groups. There was even a population in Nova Scotia, I believe, that used over 12 canisters a year. So we've normalized this to the point where this is an acceptable practice, and we really need to shake that up. But what were the consequences of that? Well, right across the board, we can see that in each of these countries, overuse of SABAs was associated with higher exacerbation risk. So it is a clear red flag, and it's now been included in CTS 2021 as an identification that their patient is at risk. If we're looking at just as a review, your patients refilled their canisters more than, they've had more than 3 canisters a year, 3 or more canisters a year, that is a red flag that they are at risk. So this is a look at a little bit of a heat map of what the population is who has received 2 or more OCS prescriptions in a 12-month across Canada. And red is the group that's received the most, so about 12.7% to 37.5%. And those who have received the least are 3.59%. What's interesting when you look at the map is that those green areas are all located close to major city centers. Yet those red and the brown and the orange areas, those are located very much at the periphery. Just geographically, I can imagine that this creates a barrier to treatment. But the question is also, how can we make sure we're expanding access for those populations as well? And that's a question, to be discussed, I think, with the new advances in biologics as well. So what is the potential risk of this OCS use? And I mentioned it before that what we thought in the past might be an acceptable dose, we're learning that lower and lower thresholds, we're also increasing the risk for other adverse events. And just as low as 2.5 grams cumulative over a lifetime, this increases your risk for things such as cataract, cardiovascular disease, osteoporosis as well. And what does that mean? What does that translate to? It's a bit nebulous, 2.5 grams. Well, if we look at the average treatment recommendation for an exacerbation of asthma, it's anywhere from 40 to 50 milligrams per day, 5 to 7 days. And that can equate to about 200 to 350 milligrams of OCS per exacerbation. And I want to point out there was a study for one of the biologics that looked at the efficacy of the biologic in the severe asthma population. And looking at the patient demographics, it gave me an idea of who is this population, what is the burden that they're experiencing. On average, this population was 54. They had severe asthma for about 20 years. And in the last year, they had four and a half exacerbations. So they needed 4.5 bursts. So this is not even including the potential maintenance medication they were on. And then when I looked at the comorbidities they had, so this group of 54-year-olds, which is really not that old, 14% of them already had osteoporosis. 20% of them suffered from depression and anxiety. I think 11% of them suffered from diabetes. It was clear that over the last 20 years, the effects of that OCS that has had on their system, certainly in the last 20 years, probably not all severe asthma, but what that means for these patients, these risks are very real, particularly for this group. At 2.5 grams, this can mean 7 to 12 exacerbations. 5 to 10 grams, this can mean 28 to 50 exacerbations, which may seem a lot right now, but when you think about that lifespan, it's really not that much. And at over 10 grams, this can mean 50 plus exacerbations. So a call to action. So there is a need to protect our patients from potential overexposure to OCS. We have the data that clearly shows that there's much more risk associated with the benefit now. And looking towards new therapies to mitigate that risk for the patients and still give them asthma control. Inappropriate OCS use is associated with serious AEs and increased healthcare costs. SABA overuse is a clear indicator of poor asthma control, leaving them at risk for exposure to OCS use. And these new therapies which are emerging are something we should be directing our patients to. So I'll stop there and I will hand it over to Mr. Naylor.
Thanks, Stephanie.
You're welcome.
So yeah, I'm going to talk a little bit about Adelphi consensus. You might have seen the word precision. You see it at the bottom of this slide. You might have seen it in some other slides. Precision is an above-brand vehicle or initiative that AstraZeneca funds and really looks at disease modification, disease management, recognition. This is about focusing not on therapeutics so much as assisting healthcare professionals in identifying these patients and moving them through a system that makes sense. And so some of you, in fact, probably many of you, actually participated in this Delphi study, which you'll see in a second. Essentially, a Delphi study gets a number of experts together. In this case, it was 11 severe asthma experts, one of which is in the room, as well as Dr. Kaplan, who was here last night, was also part of it, and many would recognize many of the names on the screen. They get together and they develop these consensus statements, or they develop statements around the management of severe asthma, and then they work towards consensus on the statements. In the end, there were 43 statements that they all agreed identified the needs of the appropriate management and referral and identification of severe asthma. Then they send them out into the wild to other healthcare professionals who then review the statements and either agree or disagree. And some of you might have participated in that. There were 150 responses in that. In the end, 41 of the statements achieved consensus. Those statements go back to the 11 severe asthma experts and they developed 10 recommendations on them. And just so, again, the reason I say some of you might have been involved, because of the 150 respondents, a third of them were CREs. So if you were involved, thank you very much. You really helped direct sort of information that we can bring then to policy and decision makers to impact the care of patients. So thank you very much for that. These are the 10 key recommendations. I'm not going to read them off. These are all published in open access publications, so you're welcome to look them up. But essentially think of it as primary care. We need to get better at identifying patients in primary care and moving them through a process. We need to think about our partners in primary care, so not just physicians, but educators, CREs, pharmacists, all can play a role in this, especially when it comes to SABA overuse or oral corticosteroid. Regular use of oral corticosteroids, patients may not be able to recall to you how often they've used oral corticosteroids, but pharmacists often have access to that kind of information and they can support those decisions. Well, so there should be access to diagnostics like spirometry or lung function testing or blood work, and it should be fairly fast, within 4 weeks ideally. A consistent pathway, whether regionally or nationally, would help streamline the process such that practitioners would know how to follow through the process. All patients should have access, of course, to an educator, and then the choice of biologic therapy, if that is what ends up happening with the patient, should be driven based on evidence. And then it should be fairly rapidly started in patients, ideally within 2 to 4 weeks. And then patients should be included in that decision-making process, obviously. The other one mentioned there is a national pan-Canadian data collection, and I think that's an important piece too, because we would really like to have a better understanding of what the face or reality of severe asthma is in Canada. So Stephanie mentioned earlier on that it's about 5 to 10% of patients are thought to have 5 to 10% of asthmatics are thought to have severe asthma in Canada. And so if we do a little mathematical exercise again, and think about that, so the prevalence of asthma in Canada is 8.4%. We think of the asthma, or the average primary care practice is about 1,800 patients, we'll say. So that's 150 patients in any given practice that have asthma. Of that, somewhere between, I'm going to say 3.7% and 10% of those patients will have severe asthma. That's somewhere between 5 and 15 patients in any given primary care practice. When I ask primary care practitioners how many patients they have that are on biologics for severe asthma, usually the answer I get is 0. And so there's probably a couple of reasons there. One, they may not even know that they're on biologics, or the second one is that they haven't recognized severe asthma in their practice. And it's probably a combination of the two. So I'm going to switch gears, talk about novel targets. I'm going to show that confusing picture again. Apologize for that, but we're going to focus on it a little bit here. Asthma is obviously a complex inflammatory disease with lots of different triggers, allergens, bacteria, viruses, pollutants. Several things engage the inflammatory system. And so to understand it a little bit, dendritic cells react to allergens or to viruses and bacteria, and they cause the release of cytokines. Cytokines are proteins that exist in the immune system, and they are immune modulators. So they're messengers. They send messages to other cells to class switch, to differentiate, to release other cytokines, which all in the end leads to sort of maturation, proliferation, and degranulation of inflammatory cells. Think of mast cells, think of eosinophils, think of neutrophils. And that continual process of maturation, degranulation, when they degranulate, they of course release all of their cytokines, which just recruits more cells to the area, and that causes more inflammation. Several of the targets, there are currently 6 biologics available on the market, and all the targets are up here. IgE, the one that sort of the oldest biologic, would be Xolair or omalizumab. It binds to IgE and sort of downregulates the production and degranulation of mast cells. The IL-4 and IL-13 is dupilumab or Dupixent, so it actually binds to IL-4 receptors. They happen to be co-located with IL-13, so that downregulates both of those receptors or those cells from producing more cells. Eosinophils have three medications that target them. So mepolizumab, which is Nucala, benralizumab, which is Fasenra, and reslizumab, which is Syncare, all target either IL-5 or the receptor on eosinophils. And then the new kid on the block is anti-TSLP therapy. And you see TSLP is a little higher or earlier in the inflammatory process and can potentially impact several of the processes. So maybe for patients that have poorly defined inflammatory processes or multiple inflammatory processes, it may be effective in those patients. So these are the 6 biologics currently available. I've mentioned them already. They're really indicated for moderate to severe asthma. Some have requirements for eosinophils, some do not. Some have requirements for control status, some do not. These are the Health Canada indications, which differ from coverage indications, or they're not indications, but most of these drugs you don't access by writing a script and sending a patient to the pharmacy. They go through patient support programs. Patient support programs are enablers of getting these patients on medication. and they're experts in understanding what either governments or third-party payers expect in terms of what patients present with so that they're covered. And so they're a vital part of using biologics. And it's important to get the right biologic on the right patient because they're not inexpensive biologics either. So you want to really target them. And then there's various age indications as well. A couple of them are indicated all the way down to 6 years of age. That would be Nucala and Xolair. And then there's others at 12 and 18 as well. Dosing, so anywhere from every 2 weeks to every 8 weeks, depending on the medication and sometimes depending on how you're using that medication. All but one of them are available subcutaneously. One is an IV infusion. Syncare is the IV infusion. Because the others are all subcutaneously delivered, prefilled syringes and auto-injectors are a possibility. So patients that practitioners are comfortable that they can take it on their own and they can use their own medication. They don't have to present to patient support or to infusion centers or anything like that to get their medication. So that meets the needs of patients. All but Syncare can meet that need. And then most common adverse events. So these are the most common adverse events, greater than 1% reported in the product monographs for all these products. Generally speaking, they're in the 1 to 3% range. These medications are fairly well tolerated with a low side effect profile typically. I'm not going to really get into efficacy of them other than to say that they work in certain people when the right medication is picked for the right patient. And it can be typically between a 40 and 70% reduction in exacerbations and obviously reductions in oral corticosteroid use from whatever they're on to potentially no oral corticosteroids. If any of you have patients on biologics, you've seen the gamut. Some patients have profound responses to these. They don't have exacerbations anymore. They don't use Ventolin anymore. They kind of live like they don't have asthma. They take their, they get their injection, they still take their regular medications, but they're not taking oral corticosteroids anymore. They're not missing work, they're not missing school, anything like that. And so, just to sort of summarize, it's important to differentiate between uncontrolled asthma and severe asthma, confirm the diagnosis, address adherence and technique and all of those things that you do so well, rule out mimickers, which you may work with your primary care practitioners around that. If they're well controlled on high-dose steroid or not well controlled on high-dose inhaled steroid, then they should be considered for referral to see if they're eligible for biologics or if there are other things going on with them. And then it's important to refer them to characterize the phenotype as well, which is often either just blood work or it might be allergy testing or both, or it might be sputum cytology, depending on where the region of the country you're in. And then so why refer to a specialist? Obviously they're experts in this area, but they do it more often. So, and some of you may be involved with specialists in this process when you gain a level of expertise when you do something regularly. So it's important to do that. It's also important to have skill in interpreting the biomarkers, but also innovative care models do have positive outcomes. And although this is an old study, this is from the UK from 2009, so this would be pre-biologics for the most part, just having a difficult asthma service reduced healthcare use, improved lung function and quality of life, and reduced medication burden. I am sure that when you add biologics in there, you see that all of these are improved even yet again. And so a simple way to think about it too is, well, have your patients had 2 or more doses of oral corticosteroids in the last year? That's an indication for consideration for referral, again, assuming that they're adherent and taking all their medications properly. If they've ever been admitted to the ICU or intubated for severe asthma, obviously that's a consideration. If they've had unscheduled visits for asthma, either to the ER or to your office or to primary care physician's office, again, more than 2 of those, or 2 or more of those, then it's a consideration for referral. And finally, SABA use, which we've already addressed. So 3 or more canisters a year in a patient that you know is adherent to their medication and is taking their medication right is a consideration for referral as well. And then just thinking about biologics and assessing them, whether they work or not, right? So that's important. So after 3 to 6 months, you should evaluate whether it's working or not. And then if it is working, then maybe if they're on oral corticosteroids, regular dosing, you're going to want to start dropping that dose. There are dose reduction strategies for oral corticosteroids that can help you out there, because you need to be aware of, if they don't mount a cortisol response, then you need to be aware of that and be very careful when you're reducing oral corticosteroids. But for many patients, the very real outcome on the right biologic is that they're not on oral corticosteroids anymore. If they're not on oral corticosteroids anymore, and they're now on high dose inhaled corticosteroids, you can consider dropping them to medium dose. Current recommendations still maintain that patients remain on medium dose inhaled corticosteroids and LABA as their primary treatment, and then biologics as well. Now, it says here in GINA to reevaluate the need for ongoing biologic therapy. There is no evidence to date to suggest that this modifies the inflammatory response of patients. In fact, there is evidence to suggest the other. When patients discontinue biologics, if they're working, they revert back to the same situation they were in before they were in biologics. So I'm not sure exactly what GINA was getting at when they wrote that. But also, if it's unclear whether it's working or not, then you want to continue the therapy they're on just to get sort of a longer view of it. And if it's not working, then you should stop that biologic. You should reevaluate their phenotype and see, sometimes switching biologics, even within the class, can make a difference. So like you've got 3 choices for anti-eosinophil therapy. So sometimes one won't work and another will. Or you can consider using one of the other biologics as you really begin to understand the phenotype of that patient. And then stop ineffective therapies, right? And return to what you've got, reevaluate everything. And sort of that's it. So thank you very much. I don't know if there are any questions or not. I'm Adana. It's okay.
So thank you, Rod. That was awesome. So I'm just going to say a few things, and then I'm going to ask my questions. So as you know, Best Care in Ontario has a big political. Best Care in Ontario has a big political strategy happening to bring to the forefront case managers, CRE, the group in this room. So when we talk about our system, you're talking about severe asthma and trying to find those patients. And as you know, there's nobody to help primary care find those patients. The people in the room who needs to do it.
Yeah.
So my question to you is, the Delphi excellent consensus statement, I've read it, it's excellent. So my question to you is, now what? Everything sits on a shelf. What are we doing with this consensus statement? AstraZeneca's led it, and I just would like to know what's next.
Yeah, so that's a great question, right? I'm not exactly sure. I mean, you're right, we did produce this. This is part of the dissemination, right? Hopefully people like yourself can, pick up the torch from here and identify these patients. I'm not sure whether there's, I'm just being very honest with you, right? We published this. I'm not exactly sure what we're doing right now. It's a great question. I could certainly find out, but
There's some work in the
I can
background.
help, yes.
oh, good.
Yeah, I can help answer that question because I was part of the group. So the part 2 is implementation, and we are looking at advocacy. And there is a company that's been hired to do some of that government relations, and that's the second part of it. So, and you probably can see when you read those statements which ones I was really influencing, because there's a really large emphasis on the importance of CREs in the system. But for sure, completely agree. It's fine to say this is what we want, but to take that into practice is a lot more work. But the point of the project was to start with what's the best standard? What is our goal to achieve? And we are absolutely a long way from achieving that goal.
Is the advocacy, are you looking to go across Canada, or are you looking to start, because that's a big task.
Yeah.
Or are you looking to kind of start in certain areas?
Yeah,
or
so
you just don't know yet?
Yeah, it's really early on the government advocacy side. So that was a large part of our conversation as a group, was what's next. So I think we'll wait and see where we're going with it, but, you know, because it is necessary, and it's just aspirational without the implementation plan. So.
Like part of this is grassroots too, right? Has to be grassroots initiatives that grow awareness as well as so again, I said I'm not aware, but I mean, it could be that our policy people are engaging leaders in that as well, right? So I don't have visibility to everything we do, but I'm sure that there's something in there. You probably have more visibility than I do, actually.
There is work with our policy group right now. I think the specifics, I'm not sure, but as Cheryl mentioned, there is a look to engage governments in that, and the conversation is ongoing. And even follow up to this publication, the Delphi, there was a subsequent publication by Dr. Godbout, who was from Quebec, and she was one of the key authors on the first one, and really narrowing down the specifics on, you know, who are these people that participated in this, and what is it that they can do from the reality of their practice. So the conversation is definitely continuing, and there is work behind the scenes, although we probably won't see it until the actual results come out. But I do know that there is work behind the scenes with our policy group to try to pull this into practice, and with, you know, working with people like Cheryl and other key advocates in the country.
Okay, well, thank you very much. It was really great.
Oh,
There's another? Hang
Yeah,
on.
sorry,
Oh,
Cheryl,
sorry.
you can't see me.
Oh,
I'm
yeah,
so
the light's
tiny,
on me, yeah,
and
sorry.
I'm wearing black. It makes me smaller and thinner. I really don't have a question. I just want to affirm some of the things that I've heard here and the work of the CREs and the CNRC. With respect to the first presentation, we heard about cardiac disease, and those, you know, the lungs and the heart are kind of married together and they can't live apart, and how important the CREs are in finding cardiac disease. And so to keep our eyes open for that, especially those of us who are working in primary care, because we're assisting the physicians and the nurse practitioners and the other healthcare providers. So I really thought that was a good thing for us to keep in mind. And that maybe we need some more information and education in that area. And then the other thing about severe asthma, if there's so many of them in primary care, we're the ones that are going to be seeing them. So we need to be aware and looking and moving that forward again. So working as advocates for the patients who maybe are being missed. I'd love to see respirologists and cardiologists and fam docs get together and get some kind of a statement about how we work together. I've heard cardiologists from the United States talk about how little they know about respiratory health, so they never think about COPD when they're working with their patients or asthma. So that's it.
Okay.
Thank you.
Thank you, Andrea. And thank you very much. Really interesting conversation. And thank you very much to AstraZeneca for sponsoring these two great talks today. So right now we're going to be moving into workshops. So all of the rooms for the workshops are on this floor. So the workshop 101, Breathing Life into Inhaler Education, a CRE's perspective, is in the Prince of Wales. Head towards the washrooms and keep walking. You'll find that room. They say they're exercising, but are they really? Measuring fitness in small office settings and even virtually. There's a hallway just to the right of the elevators. You'll see the Balmoral room. That's where that one is. Workshop 103 will be taking place in this room. So if you, and this is the workshop that will be streamed for our virtual audience. When they say quitting is killing me, maybe they're right. Managing medication during smoking cessation. And last but not least, Under the Covers, Sleep's vital role in both the development and management of respiratory disease is in the Oxford room, and it is down the hallway beside the elevators as well. And we'll have those workshops take place for 75 minutes, and then we'll have a half-hour break in the exhibit hall with lots of goodies to keep us energized for the afternoon. So enjoy the workshops.